Good morning, everybody, and welcome to this, what I would regard as a very important session. And those of you who've remained on are going to be given a wonderful opportunity to hear from three of our leading clinical academics in a session fundamentally looking at outcome. It certainly is my belief that our specialty is fundamentally dependent on research and academic output to maintain its future viability. So just in case you're confused, this is the session involving evolving practices and evolving outcomes, so I hope you know you're in the right arena. And there are just a few other brief housekeeping notes. Please make sure your phone's on silent. And that seems to have distilled down as well, so that's all we need to say. I'd like to introduce our first speaker, who's extraordinarily well known to our specialty, and that is Professor Kate Leslie, who has had an extremely illustrious career in our profession. She's been previous president of ANSCA. She's been chair of the Committee of Presidents of Medical Colleges. She is a specialist anaesthetist and head of research in the Department of Anaesthesia and Pain Management at the Royal Melbourne. She's chair of the ANSCA Trials Group, executive, and her research interests include sedation, depth of anaesthesia monitoring, and large perioperative trials. I'd like to welcome Kate to speak on drug choices, evidence for improved outcome. Thanks very much, Kate.
Thank you, Guy, and I'd like to take the opportunity to congratulate you on your ascension to the throne of the ASA. I know that you're going to do a fantastic job, and I hope you really enjoy it, as well as all the hard work that these roles entail. So good luck. Well, I've been asked to talk about anaesthetic drug choices and evidence for improved outcomes. And I thought I'd start the talk by having a look at what's in our top drawer in terms of the drugs that we've got to use these days. And this is sort of what's in the top drawer at my hospital, excluding the local anaesthetic drugs and the antibiotics. And when you look at that, there's about sort of 40 drugs there, and that's really our sort of palette for our art of anaesthesia. And there's really only one drug that's been, I don't think I can point, that has been released in the last 10 years, and that's Sugammadex. And through some means, my director has been able to get that to us in virtually unlimited supply, so that's been great. But Paracoxib is the previous drug that was introduced, and then some of those drugs are very, very old. And I only use about half of them on at least a weekly basis. So I think we haven't got very much to work with, really, in anaesthesia, and so the trick is to use the drugs that we've got as well as we can. And there's really not much in the way of new drugs on the horizon. There's, on that graph there, the red and blue lines are anaesthesia and pain medicine drugs, respectively. And you can see that there was a big surge in development in the middle of the last century and then in the 1990s. And in 2010, there were no new molecular entities registered in terms of anaesthesia or pain medicine drugs. That's new classes of drugs. And why is this so? Well, there's been increasing regulatory activity in the drug area, constrained healthcare budgets, so there are fewer purchases. There's some key patent expirations, including drugs like Nexium, which are just going to suck money out of those companies' coffers for R&D. Fewer of these large drugs new drugs are coming from large drug companies, and others are from small venture capital organisations. Anaesthesia is not a key market because we don't take anaesthesia twice a day. We only take it from time to time. And the manufacturers of analgesic products are more concerned about diversion of their products into unregulated markets or in criminal activity, and are working towards changing their drugs to prevent that. So we really don't have any new drugs, and don't hold your breath. So in this new millennium, I think we've got some new priorities, and I have new priorities because I've taken up more orthopaedic trauma. But orthopaedic trauma is just an example of patients who come to the hospital with a pre-existing pain problem. So an example is, someone I did on Monday, a 25-year-old man, he's a smoker, been in hospital for 14 days, and he's come back to the operating room for removal of the X-fix and an ORIF of his tibia, and he's taking oxycodone, pregabalin and paracetamol. So for this man, rapid emergence from anaesthesia is not a priority. In fact, our recovery room colleagues would be much happier if he was a bit sedated. Doesn't need any muscle relaxants. His risk of PONV is low because he's tolerated all those drugs and he's a smoker. So my priorities now are to make sure I get the appropriate antibiotics into him, make sure that I've got my VTE prophylaxis all sorted out, manage his acute pain and prevent chronic pain. So that's really what my talk is going to focus on. So chronic pain is pain that persists for 3 months or more after anaesthesia or the surgery, and occurs in a surprisingly large number of patients. It's associated with severe acute pain and wound complications, so that's a good incentive for us to act, and it results in reduced quality of life. So it's a major role for us. So what I decided to do in this lecture about evidence for improved outcomes was to look at whether there was any evidence for improved pain outcomes from the use of 4 very old drugs that have been around since before I was an anaesthetic registrar, and which I'm now using regularly in my practice. So the first one is nitrous oxide. And as you are probably aware, we've done 2 trials on nitrous oxide in the last 10 years, the Enigma 1 and the Enigma 2 trials. So the Enigma 1 trial had 2,000 patients, and the Enigma 2 trial had 7,000 patients. And the patients in the Enigma 2 trial were at risk of myocardial infarction. There was a different amount of oxygen in the 2 groups in the Enigma 1 study, but not in the Enigma 2 study. And the primary outcome in the Enigma 1 study was hospital length of stay, whereas in the Enigma 2 study, it was a composite endpoint of death and major outcomes. Here's a composite table of the baseline characteristics in the two groups, just to show you that they were slightly different. On the left, there's the two nitrous oxide groups, and on the right, the two nitrous oxide-free groups. And you can see that in the Enigma 2 study, the patients were older, more likely to be male, more likely to be ASA 3 and 4, and more likely to be having vascular surgery. But interestingly, the durations of stay were the same. So Enigma 1 was completed in 2006, and perhaps there's hospital service factors that have resulted in reducing length of stays, even though the patients were much sicker. And these are the results. So you can see that the patients in the Enigma 2 study were more likely to die, more likely to have myocardial infarction. And there's an interesting difference in the rate of severe PONV between the two nitrous oxide groups, and what that's due to is an increased use of prophylactic antiemetics. But what I would like to point out is the chronic pain study. There was a sub-study of Enigma 1 looking at chronic pain, and what it showed was a rate of 15% in the nitrous oxide-free group and a rate of 7% in the nitrous oxide-containing group. This was highly statistically significant, and it implied that nitrous oxide administration during anaesthesia may be able to prevent chronic pain. Now, that would be amazing. So we've done a repeat on the study, the Enigma 2 study, and those results will be presented at the ASM in Adelaide next year. So if that is really true, that's a great reason to use nitrous oxide in patients at risk of chronic pain, and that's what I've been doing since these results came out. So the next drug that I'd like to talk about very briefly is ketamine. When I started anaesthesia, ketamine was an induction agent, and now it's turned into a pain medicine treatment. And this is a systematic review, so this is a forest plot, and an odds ratio of 1 means there's no difference between the two groups. And you can see a range of operations over there on the left-hand side and the odds ratios on the right-hand side. And you'll notice that all of those summary estimates there cross the middle, so it means none of them are statistically significant. But you can see the one at the bottom for all of the patients is showing an encouraging trend towards ketamine preventing persistent post-surgical pain. So I've been using ketamine both for acute pain and in the hope that this effect is true. And our colleague Phil Payton, who's at the Austin Hospital, is mounting a large trial to see if he can prove this in a large trial setting. So we're doing a pilot trial called Rocket. It's in adult non-cardiac surgery patients at risk of chronic pain, including breast surgery, inguinal hernia surgery and thoracic surgery. They're getting low-dose ketamine for 24 hours and we're following them up for 6 months. So that's going to be very interesting. And if the pilot study pans out well, then we're going to try to do a multi-centre trial. So the next drug that I'd like to talk about is clonidine. So clonidine is a drug that was originally introduced for the treatment of hypertension, and it's been used for a lot of other indications as well. But now it's being used more and more in pain management. Well, we recently, this is some information about its use in pain management, and this is looking at morphine consumption and pain intensity. So on the left-hand side, you can see morphine equivalents for clonidine and dexmedetomidine, and you can see that clonidine is an effective drug to reduce morphine consumption. And then on the right-hand side, you can see the visual analogue scores for pain, and you can see that both drugs are also seem to be effective in reducing pain in the short to medium term. Now, the problem with all of these studies is that they were small, and also that they didn't test for hyperalgesia, which is a sign of a drug that might have an anti-hyperalgesic effect. And also they didn't check for chronic pain. So that needs to happen in the future. But the interesting thing about this was that not only was morphine consumption reduced, which no one really cares about, but also the rates of nausea and vomiting were reduced, and that's an important endpoint. Although you can see there that the doses that were used, 150 to 300 micrograms, that's a typo, were quite high. Now, the other problem with clonidine is that it causes bradycardia and hypotension, and that can be a bit of a concern. And you may be aware of the POISE-2 study that was recently published that looked specifically at whether clonidine could prevent myocardial infarction. And this study was published recently in the New England Journal of Medicine, and it showed that clonidine did not prevent myocardial infarction and in fact was associated with a high rate of hypotension, clinically significant hypotension. So you can see there that 47.6% of the patients in the clonidine group and 37.1% of the patients in the placebo group were hypotensive. And there was also a higher rate of non-fatal cardiac arrest, which was actually just extreme bradycardia. And separately, they showed that hypotension was associated with independently with a risk of myocardial infarction. So clonidine is a tricky drug to use in acute pain management, and I tend to use it in patients who have got a coexisting problem with hypertension and tachycardia, particularly, for example, in laparoscopic colon surgery when they've created the pneumoperitoneum. So finally, I'd like to say some short words about dexamethasone, which you may or may not know is also an analgesic apart from its other myriad other properties. So this is a very recent meta-analysis of dexamethasone for PONV. So dexamethasone is personally my first choice for PONV, and I have to admit, till I looked at this more carefully while writing this talk, I used to grab the nearest ampoule out of the cabinet, and that could be 4 or 8 milligrams. But what this meta-analysis has shown is that the minimally effective dose of dexamethasone to prevent post-operative nausea and vomiting in the first 24 hours is actually 4 milligrams, and 8 milligrams doesn't have any additional effect. If you look at the number needed to treat over there, it's 3.7 and 3.8. Also, these studies are quite small, and they're unable to show if there are any safety concerns associated with a single dose of dexamethasone. So the interesting thing is that dexamethasone is also an analgesic, and this is a very recent systematic review on that subject. So once again, we've got a forest plot over there on the right, and you can see a bunch of estimates there of all of the different trials. If you look down the total numbers of patients recruited, you can see that there's only a couple of thousand patients have been included, so that's not all that many. But down the bottom there on the right is a red diamond, and that is the estimate of the group effect. And what that shows is that dexamethasone in a dose range between 1.25 and 20 milligrams is an effective analgesic. And they didn't demonstrate a dose response. So on that basis, I think 4 milligrams is still the right dose to give. Just finally about this, dexamethasone is roughly equivalent to paracetamol in terms of its analgesic efficacy. So it's something that's going to, if you're going to use it for PONV, you'll get some extra analgesia out of it. So our colleague Thomas Corcoran, who's in Perth and who's Irish, and that's why he called his study the PADDY study, is going to do a very large trial, he hopes, on dexamethasone and surgical site infection. So I think this is going to be very interesting. It needs to have 8,800 patients in it. Though he's chosen 8 milligrams of dexamethasone, I think to be really sure that he's getting the anti-inflammatory effects that might put people at an immune suppression effects that might put people at risk of infection. He's going to follow them up for 30 days, and there's a range of other endpoints. He's put in an NHMRC grant this year, and we'll hear very soon whether that will go ahead. So we at my hospital, we're using dexamethasone in everybody, and it will be really interesting to know whether that is harming our patients and whether we are actually improving their outcomes in a substantial way. So in conclusion, we're really still waiting for definitive evidence of improved chronic pain outcomes from the existing drugs that we're using. So my practice is to use nitrous oxide in patients at low risk of post-operative nausea and vomiting, to use ketamine particularly in my opioid-dependent patients, to use clonidine when pain coincides with hypertension and tachycardia, and to use dexamethasone 4 milligrams at anaesthetic induction. The abstract of my talk is on the website for this conference, and if you'd like a copy of the slides, you can email me at that internet address, which is freely available on the web as well. Thank you very much.
And Kate's happy to take them. We've got a bit of time. I wondered, we don't have a microphone. The acoustics are pretty good, so if you could just speak up a bit. Thank you. We have a standard protocol in the hospital, and I think that that's a key element to using ketamine safely. Along with any other drugs that are potentially going to cause respiratory depression or sedation. We use 4 milligrams per mil. I give a 16 milligram bolus and then run about 4 mils an hour, which is 16 mils an hour. And that's what's proposed, or it could be 20 mils an hour in the study. So it's in that range. It's a relatively low dose. In my practice, I started in the operating theatre, write up an acute pain form, and then rely on the acute pain team to decide when to turn it off. That's usually between 12 and 24 hours post-operatively. In the pilot study, we're studying patients who are staying for 23 hours, which includes some of the bigger breast surgery and bigger inguinal hernia surgery that's done. There's some resistance from the patients and others about giving ketamine to those people because they would normally be on oxycodone. And I think the patients really need to be convinced that chronic pain is a significant issue for some of these, what we consider minor operations, with rates of chronic pain of 20 or 30% after, in some series of hernia surgery. Any other questions? I just wondered if I could ask you one, Kate. How much, in that young gentleman with the fractured tibia, how much nitrous, if you're using it, are you using? Are you able to, is a small amount adequate?
I don't think it is. No, in the Enigma study it was 70%. I usually use 50%. When I was a girl we used 70% in everybody, but we weren't as bothered by oxygen saturation of 96% as my trainees seem to be now. They want it to be 100%. So I'm using 50%. Yeah. But the Enigma 2 studies really changed my practice. I've started using nitrous oxide in fractured neck of femur patients, and you don't need very much volatile, very stable. And there are people in the audience who probably are nodding and saying, I never gave up using nitrous oxide because of you stupid researchers in Melbourne. Then you can all feel very, very smug about that. But I'm relearning nitrous. It's fantastic.
Can I ask another one, sort of out of left field a bit? Is there any role for esmolol in pain management that you're aware of?
I'm not aware of any role for esmolol in pain management, and I don't think there's a role for esmolol in anaesthesia practice at all. It's it's expensive, and it doesn't last long enough. And I use metoprolol.
Okay.
Or remifentanil. Yeah.
No more questions?
Which is more expensive, I hear you laughing. Yeah. I'm using it anyway.
Excellent. Well, thank you. Join us, please, in thanking Kate for a fantastic presentation. And our next speaker, biomass I've lost briefly. Our next speaker needs little introduction, as he's been introduced to you before, but I will just clarify. It's Michael Barrington, and he's talking on a subject that is of huge interest to me, as I do very little orthopaedics, but if I was to return to doing orthopaedics, I would most definitely want to know the answer to the question that he's proposing, and that is, does regional anaesthesia improve outcome following major orthopaedic surgery? Because if it didn't, I wouldn't have to learn all those blocks And I wouldn't have to learn how to use ultrasound to do them either. So in brief, Michael Barrington is a senior staff anaesthetist at St Vincent's Hospital in Melbourne, and he's an associate professor at the University of Melbourne and is responsible for the development of an international registry of regional anaesthesia. And I'd ask you to welcome Michael to the podium.
Thank you for that introduction, and thanks again to the organising committee for inviting me here as the Australasian speaker. It's an enormous privilege. So my title is, Does Regional Anaesthesia Improve Outcomes Following Major Orthopaedic Surgery in the Modern Era? And I'm not here to convince you that you should use regional anaesthesia. You may be surprised that regional anaesthesia is not my major interest. Outcomes are my major interest. So that's really driven a lot of my research work in terms of developing registries. And this talk is not really designed for the expert either. It's meant really just to be an overview and try and encapsulate some of the changes that have occurred in regional anaesthesia over the last 10 to 15 years and perhaps generate a bit of discussion about where we need to go in terms of measuring outcomes. I'm going to start with shoulder surgery, and I put this slide up in the plenary session briefly. And the main reason for putting it up was really to emphasise how versatile some of our regional anaesthesia techniques are. And in the context of shoulder surgery, interscalene blockade is enormously versatile because not only can it be used as an analgesic technique, it can be used as an anaesthetic technique and therefore reduce our reliance on general anaesthesia. And I think this is one of the largest studies performed on shoulder surgery involving the sitting position, involving regional anaesthesia. It was performed at the University of Pittsburgh from 2001 to 2011, and it involved patients having ambulatory arthroscopic shoulder surgery conducted in the beach chair position, as I said, with interscalene block as the primary anaesthetic. And to collect the data, or to at least identify the events, they used departmental, institutional and statewide databases. And they also used a billing database, and that was really to capture and determine the denominator. And the total number of patients which met their inclusion criteria were over 15,000. And they used a relatively large dose of ropivacaine, 0.4 mils per kilo of 0.75%. That was in the earlier stages of the study. Towards the end of the study, they were using ultrasound, and their doses or their volumes had reduced down to 15 and 20 mils. Propofol was used as the sedative, plus or minus ketamine. So just a little bit different to what we might do, but the emphasis on their technique was to have a spontaneously breathing patient with an intact airway. And their care pathway is different to ours. The attending anaesthesiologist will supervise the resident, and the resident in this series performed over 90% of the blocks. And then once the block's established, a nurse anaesthetist is responsible for the patient in the theatre. And they really had good results. In terms of patients who had an immediate or early post-operative stroke, there were no cases in that category. They followed the patients up for the first 48 hours. There was one patient who had an ischemic event. It was a very focal event. After the patient went home, or I should say after the surgery, they returned to normality. They then went home, and at about 48 hours, they had an embolic stroke. And it was thought that this was not related to the surgery or the anaesthesia directly. Of course, there was a patient with persistent phrenic nerve injury. Wouldn't like to see this, but on follow-up at 3 months, it became evident that the patient had pulmonary metastatic disease, and potentially that was the cause of his dyspnea. So overall, they really demonstrated very good results, and as I say, I think this is the largest series in this area. Now, of course, there are always limitations to these large studies particularly. The findings clearly may not be generalisable to the non-ambulatory population. Those patients are likely to be more comorbid. Minor events would have been missed. So minor events might be minor sensory abnormalities which resolved, because we do know that these patients do commonly have minor neurologic sequelae, and most often they resolve. But also these patients, this anaesthetic group also collaborates closely with their surgeons, and the surgeons knew to refer patients back, and they do refer patients back with any persistent neurologic abnormalities. The methodology was such that no patient details were captured, and clearly there's no comparator group. For all we know, we could get similar results under general anaesthesia alone. So in conclusion, there were no episodes of intraoperative or immediate post-operative stroke, and so the 95% confidence interval for stroke is less than 4 in 10,000. Interscalene block is very effective for treating pain in the post-operative period, and continuous interscalene block is preferable to single injection techniques if you really want to have a significant impact. And in this study, they compared single injection with continuous interscalene block with patients who had no blocks at all. And they found that the patients who had the 2-day interscalene infusion at home had opioid sparing, improved pain relief and sleep and satisfaction. The interesting thing with this study was that the infusion continued for 48 hours, but the benefits were demonstrated at 7 days. Should you change your practice on this study alone? No, I don't think you should, but it simply demonstrates that we can sometimes offer patients longer-term benefits from a shorter duration therapy. Many people don't want to put in catheters. I understand that. It takes extra time, it takes extra expertise, you need more equipment, it's more expensive. So there's a big focus on using adjuvant agents. And the adjuvant agent that's been used for perineural administration, that's been studied most extensively, is dexamethasone. And as Kate mentioned, this is an analgesic. There are variable results in the literature, but in one study, dexamethasone significantly prolonged the median duration from 11.8 hours to 22 hours when ropivacaine was used for interscalene block. In my practice, I don't use dexamethasone commonly, but this large difference seems to be more than what I would expect. In another study, again, a prolongation of the duration of sensory analgesia, sensory blockade, reduced opioid consumption, associated with a bupivacaine clonidine adrenaline block. However, not all the evidence is consistent, and other investigators have indicated that the systemic effects of dexamethasone may be similar to perineural administration for lower and upper limb blockade. So at this stage, the results are inconsistent. I will routinely use dexamethasone for an adductor canal block. I'll come to that in a moment. I don't routinely use it for other blocks, and there is some question about its safety for perineural administration. So I'm not suggesting you go back and immediately use dexamethasone perineurally, but it's something you certainly should consider. There have been other adjuvant agents including buprenorphine, which has been shown to enhance and prolong the analgesic effect of bupivacaine when used for a sciatic block, and dexmedetomidine has also prolonged the duration of interscalene block with ropivacaine for elective surgery. So there's a number of options that we can consider if we want to avoid using a continuous technique, if we want to extend the duration of analgesia from a single injection technique. So now going to move to lower extremity surgery, and over the previous 10 to 15 years, continuous lumbar epidural analgesia has been gradually replaced by continuous and single injection peripheral nerve block techniques. I use the word gradual because the transition isn't complete, and many anaesthetists around the world still use lumbar epidural analgesia for major lower limb orthopaedic surgery. It's a perfectly acceptable technique. But the one technique that's really resulted in that transition away from lumbar epidural analgesia is femoral nerve blockade. And in this meta-analysis by Paul, they demonstrated quite clearly that femoral nerve block improves analgesia following total knee arthroplasty. But they did make the comment that there was no additional benefit from doing a continuous block. We wrote a letter to the editor about this because we really felt that the authors didn't fully appreciate the benefits of continuous techniques. In particular, only a small proportion of the patients recruited to that study actually had continuous techniques. So therefore, we thought it was an unfair conclusion to make. And regardless, the evidence for continuous peripheral nerve blockade in reducing post-operative pain and opioid requirements is robust. And reducing opioid requirements is a significant benefit for our patients because it reduces opioid-related side effects such as post-operative nausea and vomiting, drowsiness, other CNS effects, constipation. Patients don't like opioids. So anything we can do to reduce opioid requirements is important. Initially in 2006, Richmond showed that continuous peripheral nerve blockade was superior to opioids, and this was for the first 48 hours. And then recently, Bingham has, in another meta-analysis, is demonstrated that continuous peripheral nerve blockade is superior to single injection techniques. So there is a significant body of evidence that supports continuous techniques compared to single injection techniques. As I said, there's been a transition, and there are valid reasons or good reasons for avoiding post-operative lumbar epidural analgesia. If we avoid lumbar epidural analgesia, we don't need to deal with the less serious side effects such as urinary retention. Patients aren't going to have a sympathetic block, so they're not going to have hypotension due to that. If they do have hypotension, we know it's due to another cause. With lumbar epidural analgesia, sometimes it lateralises to the non-operative side. It can cause a sensory or motor block in the non-operative side, which impairs early post-operative mobilisation. Also in the studies, and we've talked about this in the earlier sessions, that epidural analgesia is associated with a higher risk than spinal anaesthesia, and that was demonstrated in the decade-long study by Moen. And more recently, another study has demonstrated how spinal anaesthesia is associated with a lower risk than epidural analgesia. And in this single hospital study that included 100,000 consecutive major lower extremity joint replacements, hip and knee joint replacements, they identified 8 patients with epidural hematoma, giving an incidence of 0.7 per 10,000 patients, but no patients who received spinal anaesthesia alone were affected, and no patient incurred permanent nerve damage, which emphasises the importance of good post-operative neurological surveillance. These cases were conducted at the Hospital for Special Surgery in New York. They run about 40 rooms daily. They're all orthopaedic. They're absolute specialists in this area. They have huge volumes and great expertise from that. Now, what if the use of neuraxial anaesthesia actually improved outcomes, serious outcomes such as post-operative morbidity? There's a large body of work being produced by Stavros Matsoudis, and he is from the Hospital for Special Surgery. He has an adjunct appointment in an epidemiology department nearby. He's married to an epidemiologist. He's embraced in post-operative outcomes. Although he works in a hospital that really embraces regional anaesthesia for orthopaedic patients, he, like I, is really interested in post-operative outcomes. And using large databases to address questions of comparative effectiveness of various anaesthetic techniques has really gained popularity, and with automated anaesthetic record machines and other techniques, there's a large number of studies being produced from the United States that involve large cohorts, extremely large cohorts. In this case, Stavros has used a large nationwide sample of over 400 hospitals involving 382,000 primary hip or knee arthroplasties. And this study showed the evidence for the superior effectiveness of neuraxial versus general anaesthesia for hip and knee joint replacements. The 30-day mortality was significantly lower among the neuraxial and combined neuraxial general groups compared to those undergoing surgery under the general anaesthesia. So the mortality in the neuraxial and combined neuraxial general anaesthetic was 0.1, and the patients who had general anaesthetics 0.18. And you might say, well, that's not much of a difference. And that was my immediate response. My other response was, wow, you've got to study a large number of patients to identify that small difference. But on the other hand, if we look at this from a public health point of view, hundreds of thousands of patients undergo these procedures every year. So correspondingly, potentially, patients' lives can be saved from implementing neuraxial techniques. There were a reduction in the incidence rates of in-hospital complications. They were generally lower amongst the neuraxial and combined neuraxial general anaesthesia techniques. So I put this study in front of you just so you can give it some thought. Should you go and change your practice? Should you immediately change from general anaesthesia to neuraxial anaesthesia for major orthopaedic surgery? I would say no, but I think it really demonstrates that neuraxial anaesthesia does not incur a higher risk overall compared to general anaesthesia, and potentially it may reduce mortality. Now, on a more mundane level, continuous peripheral nerve blockade has been associated with reduced time to discharge readiness, and Ilfeld did a study on patients having continuous femoral nerve blocks, and he showed a reduction in readiness for discharge, and that's a really important outcome in the modern era. But he was criticised because the first study, published in Anaesthesiology, was a single-centre study, a hospital with a lot of expertise in continuous techniques. And so he repeated the study in a multi-centre format, and it was later published in Pain, only because Anaesthesiology rejected the journal when he redid the study. And you can see in the single injection, in the single-centre study on the left, there's quite a marked difference in the readiness for discharge between the two groups. And when he did the multi-centre study, the difference was reduced simply because of differences in expertise. Again, it highlights how important local expertise and, I guess, enthusiasm and also having for these techniques, and also having good protocols to manage patients. Over the last decade, or particularly the last 5 or 7 years, I think orthopaedic surgical care has become far more coordinated and integrated. They've really become slick at getting their patients through the perioperative period, and some of the things they've done is improve preoperative assessment, with our help of course, early mobilisation, with our help of course, and they've really fine-tuned the whole process. Integral to these changes has been the institution of local infiltration analgesia. Local infiltration analgesia refers to the systematic intraoperative injection of local anaesthetics into the periarticular and intra-articular regions. LIA typically uses large volumes of local anaesthetics, for example 200 mL of 0.2% ropivacaine. Adjuncts such as ketamine and adrenaline are commonly used intraoperatively and then following the arthroplasty. As I say, further injections may be injected through a catheter, and often that's done at 24 hours on the ward. And LIA is commonly used as a component of multimodal analgesia, with its clear advantages being simplicity and taking the anaesthetist out of the equation. When combined with an organised fast-track program, LIA is associated with a reduced duration of hospital stay. But LIA by itself does not reduce the duration of hospital stay. There's no evidence to demonstrate that. There's difficulties with the methodologies of these studies. They're very heterogeneous. They often have had inferior outcomes in the groups assigned to regional anaesthesia compared to those published in the literature. They've often omitted to use the adjuncts in the non-infiltration groups, but used ketorolac in the infiltration groups. They often have not studied pain in a systematic way, and often they have not standardised their mobilisation schedules. So it's difficult to know the cause, but LIA by itself does not reduce the duration of hospital stay. So what is the evidence? And this is my summary. Following total knee arthroplasty, LIA reduces postoperative pain in the first 6 to 12 hours. There's no evidence that it produces prolonged reduction in pain beyond 12 hours. The evidence to support intra-articular administration for non-steroidal anti-inflammatory drugs is inconsistent, and that's level 1 evidence. Following hip arthroplasty, well-designed studies have failed to demonstrate the efficacy of LIA, and in the context of an effective oral multimodal analgesia strategy, LIA is not indicated. That's level 1 evidence. But hip arthroplasty is evolving. Of course, the surgeons are always advancing their techniques. New techniques are always creeping in, and some of the hip arthroplasty techniques are changing. But I would have thought if it's not indicated for a standard hip arthroplasty, then it's not indicated for a minimally invasive hip arthroplasty. And my real concern is that the real beneficiaries from these practices, in some circumstances, are the companies that make local anaesthetics. Following either knee or hip arthroplasty, there's insufficient evidence to support the use of postoperative administration of LIA, and that's level 1 evidence. Okay, so why has LIA been so popular? Why has it been driven so strongly by the surgeons? A, take the anaesthetist out of the equation. B, inpatient falls. And we know that femoral nerve blockade is associated with quadriceps weakness. There's no question about that. And we've tried for many years to reduce the concentration of local anaesthetic, but still, in some patients, they're still going to have quadriceps weakness. Of course, many of these patients have poor function to begin with and have poor quadriceps function. Another study by Stavros, only 200,000 patients this time, but from 400 hospitals. The rate of inpatient falls was 1.6%, and this is similar to the results from other studies. Interestingly, 10.9% of patients only had neuraxial techniques, so if you don't use neuraxial techniques, you're in good company. 12.9% had combined neuraxial in general, and 76% received general anaesthesia. Using their analysis, increasing age and comorbidity burden were associated with an increased risk, but peripheral nerve block was not associated with an increased risk of inpatient falls. Epidural analgesia was associated with a reduction in the risk of inpatient falls. So what can we deduce for that? Can we just say, well, just do peripheral nerve blocks, there's evidence that doesn't cause falls? I think we need to interpret this study in the practice environments that was done, and many of these hospitals would have had very comprehensive prevention programs for inpatient falls. And so regardless of what technique we use, our hospitals need to have comprehensive programs to prevent inpatient falls. And not all the studies agree with this result specifically. So what have anaesthetists done to combat LIA? Well, what's come up is adductor canal block. Adductor canal block comes under different names. It's often referred to as a saphenous nerve block. It's performed in the mid-thigh, and the reason why it's become very popular is because it is simple. The saphenous nerve is located next to the superficial femoral artery in the mid-thigh, and there are other nerves which will be involved, and those nerves include branches of the obturator nerve, but unfortunately the nerve vastus medialis may be involved as well. This is a very simple technique, and it really has attracted a lot of research in the last year. One example is this one, a double-blind randomised controlled trial. All patients received spinal anaesthesia for the surgery and single-dose LIA during the operation, and then a saphenous nerve catheter or adductor canal, whatever you want to call it, was placed in PACU. And the worst pain scores on movement on the day of surgery were significantly lower in the ropivacaine group, okay, compared to the LIA group, okay, and breakthrough pain occurred later in the ropivacaine group, okay, compared to the LIA group, and a larger proportion of the patients mobilised on day 0 in the adductor canal group. Unfortunately, in this study, the benefits weren't transferred onto day 1. So, in summary, the adductor canal blockade provides postoperative analgesia that is non-inferior to femoral nerve blockade and is associated with reduced quadriceps weakness. And it's very simple, as I said, and this is why it has become popular, I believe. You can see the superficial femoral artery on the right-hand side of the screen. You can see the needle just under the nerve now, and the injectate is now pushing the nerve to the left. The nerve's now sitting on top of the needle, and all this is under the sartorius muscle. So the sonographic landmarks are very simple. In conclusion, compared to opioids or single injection techniques, continuous techniques improve postoperative analgesia. This is over a wide range of surgical techniques. They reduce opioid requirements, which we know is a good thing. It reduces opioid-related side effects, which we know is a good thing. And this extends up to postoperative day 2. We know that femoral nerve blockade does provide better analgesia compared to parental opioid-based therapy after total knee arthroplasty, but it is associated with a motor block which may not be concordant with our current care pathways, so we have to be careful there. Continuous interscalene analgesia does provide better analgesia, reduced opioid-related side effects, improved satisfaction compared to IV PCA in shoulder surgery, and we know that interscalene block is an effective anaesthetic technique as well. Following knee arthroplasty, I just want to emphasise this, LIA has a limited benefit in the first 6 to 12 hours, and addition of non-steroidal inflammatory drugs is not warranted based on the current evidence. And in a review of 400,000 patients undergoing total hip or knee arthroplasty, major morbidity and mortality were significantly low in those receiving neuraxial anaesthesia. And that's the end of my say. And I've got my email address if you wanted to send me a message, ask for some information. And just a reminder that the Australasian Symposium of Ultrasound and Regional Anaesthesia is next February in Fremantle. Thank you very much for your attention.
We've we've certainly got some time for questions if people have them. Kate.
Thanks, Michael. Kate Leslie. The large study by Matsoudas on epidurals was, as you pointed out, a large database study. The patients weren't randomised. And one of the things that needs to be done when these studies are done is to try and pseudo-randomise the groups so that you balance out the known risk factors for death and major morbidity. Were you satisfied in your reading of that study that that had been done and that there was a possibility that the two groups were at equal risk?
Certainly the patients that received regional anaesthesia were older than the patients that didn't receive neuraxial anaesthesia. In terms of the comorbidity burdens, I can't recollect, but certainly if they were older, you would expect they would have a high comorbid burden. The methodology of this paper, Kate, is about 5 pages long. These guys are experts, so I'd actually welcome your input. If I sent it to you, you could dissect it and think of ways to improve the methodology. They're very, very aware of the limitations of observational studies, and perhaps I should have emphasised that. There's no randomisation. There's no accounting for unknown or unmeasured confounders, as there is in a randomised controlled trial, and I should have emphasised that these studies demonstrate an association but not causation. So we have to be careful about how we interpret the results of these studies, which is why this is the way I'm interpreting it. It's a signal that neuraxial anaesthesia may have a benefit.
Any further questions? Could I use my prerogative as the chair just to ask you one, Michael? Do we have a sense at the moment in Australia, for example, of what the standard of care might be for a patient undergoing a knee arthroplasty? And do you have any sense of whether that is influenced by the surgeon, the anaesthetist, the public, the private, the organisation? Surely there are multiple factors that might influence what is done. Do we have a sense of what it is in Australia at the moment?
Yeah, I think anaesthetists working in private are under enormous pressure in terms of turnover, and there's been an enormous drive from surgeons to infiltrate patients regardless of what type of joint surgery they're having, hip, knee, shoulder. The surgeons have really collaborated at a non-scientific level, I should say, very well on this, and they're really taking over this area of anaesthesia and post-operative analgesia. And this is really an important issue, because if they take over this, then we may well lose our control of acute pain medicine. So I really think it's an important public health issue. The surgeons are driving it, and it's not based on a large amount of science. They're using huge doses of local anaesthetics. The patients are being put at risk of local anaesthetic systemic toxicity, and there's been no large-scale studies on the quality of safety of local infiltration techniques performed. And as you can see, there's a huge number of patients recruited to studies looking at the safety of neuraxial anaesthesia. I presented that the other day, something like 7 million patients from 1990 to 2013. It's not to say it doesn't have any merits in clinical environment, but I think it's been understudied and really pushed by the surgeons. And I think in private practice, anaesthetists are under more pressure than in public practice, but I'd be willing to hear what people have to say, what they think.
Comments, questions? Yep.
Yeah, to the second question, I think intrathecal morphine has been understudied and warrants more investigation. It's a simple technique, doesn't require much extra preparation. Having said that, patients having hip arthroplasty, some patients don't get a lot of pain, despite it being such a big operation. It's quite interesting. My understanding, I'm not sure whether we're referring to the same study by Matsoudas. He's done so many of these studies now. The study that I was referring to was patients having elective hip and knee arthroplasty surgery. Sorry? But I take your point. If there were emergent cases, they should be treated differently.
Thank you. Any further comments or questions? Well, thank you very much indeed, Michael.
Okay.
Great talk. Thank you. Our final speaker for the session is Professor Adrien van Zundert. He's the Professor and Chairman of the Discipline of Anaesthesiology at the University of Queensland, School of Medicine and Biomedical Sciences. He has a PhD from Leiden that covered aspects of epidural analgesia and childbirth. And I would understand that until 2013 he was still in the Netherlands in Eindhoven and is now here in Australia. And his talk is entitled Improving Airway Outcomes. Does Videolaryngoscopy do a better job than classic laryngoscopy? Adrien.
Thank you, Mr. Chairman. Ladies and gentlemen, thank you for staying this late on the program. I'm very privileged to be invited to give a talk on videolaryngoscopy, and I really think laryngoscopy is very important in our, we all are using some sort of a laryngoscope in our practice, I guess. Yeah? So I was thinking videolaryngoscopy, should that be a title for the laryngoscope, the choice of the laryngoscope in the 21st century? Let's go back to the 1940s. Beautiful cars here, as you can see here. And what do they have in common with cars from the, in this year, 2015? Yeah, all cars, and the similarity is that they have many things in common. But for most of all, they have in common that they bring you from a point A to a point B to a point C. Okay? Nothing special, but that is what's happening. Yeah? But these beautiful cars nowadays have something extras. They have safety belts, they have airbags, and lots of things I don't know anything about, and a reverse camera. I like the reverse camera nowadays. Yeah? All kinds of safety features. That is the difference between cars in 75 years ago, the 1940s, and nowadays. So you have these safe belt and airbags. Hopefully you will never know where they are. Hopefully you will never need to use them. But in case you need them, they are there. That's my reverse camera. So I bought a car here with the reverse camera, and I like it very much. So also the tom-tom helps you very much in bringing you from point A to B or C. Now go back to the airline industry. We have these beautiful planes nowadays, the Dreamliner, with lots of features. It's very enjoyable to be in one of these 787 Dreamliners, and it's all about luxury, but foremost about safety. The safety issues and the features in that plane are enormous. Yeah? And of course, I'm not biased. The Airbus 380 has similar features to offer. Now let's go back to the laryngoscope. The laryngoscope from the 1940s, in fact 1943, when Sir Robert Mackintosh developed this laryngoscope, and in fact this is the original one, and he did that together with a skilled technician, Mr. Richard Salt, who developed the Mackintosh laryngoscope. And still nowadays we are using some sort of a laryngoscope which very much resembles this. And what we are doing, we are trying to expose the glottic entrance so that we see it clearly and try to intubate between the vocal cords. But the success rate of a classic laryngoscope is roughly 90%. And I define the success rate that is a Cormac-Lehane grade 1 or 2, because an unsuccessful laryngoscope, where you don't see that much, a grade 3 and 4, that should be considered like a failed laryngoscope. And it almost is the same as if we are going to do a blind intubation. So failed intubation without the use of adjuncts, roughly 10%. With the use of adjuncts, for instance, a gummy-elastic bougie, 7%. Can't intubate, can't oxygenate situation, less than 1%. Now, suppose I'm the pilot and I'm telling, ladies and gentlemen, this is your captain speaking. Today we are scheduled to fly from Sydney to London, and we just had a minor problem fixed, and now we are 90% sure we are going to make a safe landing. Are you boarding this plane? I'm not sure. Yeah? Because failed intubations, like landing a plane, as you can see in here, it's like a blind intubation, or it even can be worse, that you don't see anything. So I think we should do a better job, and we can do a better job by using videolaryngoscopy. Videolaryngoscopy, and I'm talking about all these different brands, because we had them in my former position, we all had them at our disposal. So we could use whatever videolaryngoscope there was on the market, we could use them in any of our patients undergoing general anesthesia. So we were very fortunate, and we did many of these comparative studies, finding out which is the best one. So are there differences between two videolaryngoscopes, or what to look at? Yeah? Where to look at? And my first publication was already in 2007, the first publication on the CMAC. That was in 2007, yeah. And the videolaryngoscope offers you that you can see much more than usual. This is what you can see. You see the vocal cords, you see the epiglottis, the arytenoids, and even the esophagus. And that is what you want to see. You want to see a clear view of the whole lot so that you can do a good job. But what it is, yeah, you can compare these videolaryngoscopes, and you can see there are differences in the scopes. For instance, here on the left side, you see the light intensity expressed in luminance candela per square meter. And on the abscess, you see different laryngoscopes and videolaryngoscopes. And you actually can see in the dark, the dark areas, that is in the dark room, taken without no ambient light, and the gray areas, that is when you're doing the same recordings into actual operating theaters with ambient light. And you see there's a quite large diversity in the luminescence of the light production of these videolaryngoscopes, and you actually want to see it. So it is very important to look at these. On top of that, you see more. See at the bottom side, can I use this thing? No. No, this is not working. But at the bottom side, you see that in a classic direct laryngoscope, you see 15 degrees. That's the angle of view you have with a normal Macintosh blade laryngoscope, direct laryngoscopy. With videolaryngoscopy, you can multiply that by 4, and it's instead of 15 degrees, it's now 60 degrees. So you see much more of what you want to see into the oropharynx. And within a couple of months, I had a registration of a number of kysts and tumors, and on the bottom right, you see a forgotten tablet to swallow, and all kinds of things which I never saw before. Videolaryngoscopy, and this is the work done by Keith Greenland from Brisbane here. As you can see, normally we look from a distance 40 centimeters away, yeah, into the mouth, looking at the glottic entrance. Yeah? And what we want to do is to go around the tongue and find the opening of the glottis. With videolaryngoscopy, we bring our eye very close to the entrance, and we actually see there. So the alignment of all the axes, the 3 axes, is no longer necessary. And here again, you see the operator's direct line of vision. That depends on the width of the blade. Yeah? So that distance is very important, and if that is increased, you will see less and less of the direct line of vision, but also of the video line of vision. So it's very important that engineers constructing, focusing on the blade itself, they should pay attention, and they should talk to us as clinicians what we want to have it as features. Yeah? Videolaryngoscopy is easy to learn. For instance, you see me on the left side, yeah, in the normal position when you are doing a direct laryngoscopy with a curved back, and it's much better to be in the standing position with a straight back, avoiding back problems maybe. And as you can see on the right side, you see very clearly that you have that hand-eye coordination to do an intubation. And youngsters are very good in doing that, and maybe the more older anesthetists have more difficulties in doing that. But in fact, everybody can see it now in the room. It's a better instruction tool than look over my shoulder technique. And in fact, when I started doing this, and that's now 8 years ago, doing all my cases with videolaryngoscopies, surgeons came and they wanted to know why I was playing with their tools, because they were doing laparoscopies with monitoring, etc. And they were asking me why we were doing that, but then they actually could see how difficult it could be to do an endotracheal intubation, and others could help in a much better way to solve a problem whenever we had a problem with a difficult airway. So with a videolaryngoscopy, you see more, it's more comfortable, it's easy to learn, especially that hand-eye coordination. The insertion technique, direct laryngoscopy versus the intubation in using an indirect videolaryngoscope, is an easy technique for teaching purposes, no more look over my shoulder technique. All team members can see it and help in a better way, and it's easy to make recordings for later discussion. It also solves the difficult laryngoscope. You know the Malapati scores and the Cormac-Lehane scores, and for instance in this study on the left-hand side, published in Anaesthesia and Analgesia, it's about 600 patients where you actually can see the normal Cormac-Lehane distributions. In the purple, you see the grade 1s are more than the grade 2s and the grade 3s, and very little grade 4. But with videolaryngoscopy, and that is the blue column, you see most of the time you have a Cormac-Lehane grade 1 or 2. And that's in normal airways. In a group of obese patients, and very obese patients, patients weighing 200, 300 kilograms, we thought that's a group of obese patients that can be regarded as a difficult airway group, which was not always the case. But if you look at the Cormac-Lehane distribution, you see the trend towards the more difficult grades. Yeah? Nevertheless, with videolaryngoscopy in the same patients, you could see that the distribution is going towards the Cormac-Lehane grade 1 and 2, and very few others. Now, companies like the GlideScope and the McGrath originally said you need to use a styletted endotracheal tube. And I'm very much in front of the left one, the stylet produced by the GlideScope company. It's a very good one, and use the 90 degrees stylet, not the 60 degrees. That has been published that the 60 degrees is of less value. So use the 90 degrees stylet. So, but I was very surprised to find in the literature the palatopharyngeal wall perforation that was associated with videolaryngoscopy. This is in 2007, and the Canadian Journal of Anaesthesia and the Journal of Clinical Anaesthesia, the Airway journal. And that's strange that you say, look, you have to use now a new technique, but you have to use all the time a stylet, and that causes problem. That's not a good solution to me. And it's a long list, as you can see here. I stopped listing them, but it's all about palatopharyngeal wall perforation, anterior tonsillar pillar perforation, pharyngeal injury, listed and related to GlideScope most of the time, McGrath, and also recently to the air track. We did a mannequin study just to find out what could be the reason. And you see on the top left, number A, that's a classic direct laryngoscope. The B one, that's the CMAC videolaryngoscope, both Macintosh-based. The C and the D are the GlideScope and the McGrath, and the E and the F is the Pentrax and the air tract. Now look at the distance between the palatopharyngeal fold pity I can't show that. The palatopharyngeal fold and the blade. And the distance in A and B is roughly around 15 millimeters. Now we know the endotracheal tube diameter is 8 millimeters, more or less. Yeah? So there's a lot of space and a lot of room to manipulate and insert extra thing like a Magill forceps or a naso or an oral gastric tube. With C and D, the distance between the blade and the palatopharyngeal fold is reduced to about 8 millimeters. So 8 millimeters, that's just the space that can fit an 8 millimeter tube. And that is the reason why you have these perforations. And with the Pentrax and Airtrax, it's even less. Yeah, it's 5 millimeters. So you can take your own conclusions. And is there a need for that burp maneuver and cricoid pressure when we are using videolaryngoscopy? Look at the top patient. Patient number 1, you see when there's no pressure, yeah, there's a quite substantial area under the vocal cords. But when you're performing burp maneuvers and cricoid pressure, you see that area under the vocal cord is decreasing. And I can show you at least 300 of these patients because we all recorded them. And it's each and every time it's the same. Now suppose, in patient number 2 that you only see this. That is when you start using burp maneuver and cricoid pressure, okay, in order to see a little bit more. But that same patient, now you have to see just in the center, that same patient has now very little opening under the vocal cords. If you're protruding your endotracheal tube through these vocal cords, I can imagine that can create a postoperative hoarseness or sore throat. And I think you agree with me on that. We should avoid traumatizing the vocal cords. Now look at this one. These are you see what happens here? You see epiglottic downfolding. Epiglottic downfolding, I think we are still studying it to find out what is the real incidence, but I think it's roughly between 8 and 10% of all of our cases. And most probably have never seen this. Yeah? And this is just what happens if you do that. This is how it should be. Insertion, you see the 2 black lines on the tube. The vocal cord should sit in between the 2 black lines. That is the correct position of an endotracheal tube. Look again at this video clip. We do a very slow recording so that you actually can see it. This is epiglottic downfold. You would say, okay, fantastic view. I can do my intubation, but now the epiglottis is trapped between the tracheal tube and the tracheal wall. And that happens in 8 to 10% of all of our patients. And you don't know. Because I know it, I think it's not ethically to leave it in, so I restore it. Just to give you another one. Oops, sorry, it was too quickly. Yeah, this one. It's another one. Just to show you, it really happens. Yeah, in a blink of an eye, you get this view of the larynx. You would say, okay, fantastic. I'll just pop in my endotracheal tube into position. But still, if I withdraw my laryngoscope, the epiglottics will be trapped between the tracheal wall and the tube, the endotracheal tube. And if that is going to be for 5-6 hours of anesthesia, I can imagine that will be the reason why patients have a sore throat after our operation. Yeah? Of course, I restored that immediately. Epiglottic downfolded is well known for laryngeal mask. It's also known for fiber optic intubation. And we published that in Anaesthesia Analgesia a few years ago. So epiglottic downfolding. Another issue with intubation is that it can create trauma to our teeth. Now, can we avoid that? Yeah? We always teach our residents how to do it, do the intubation, going away from yourself in that direction. But when it starts to become difficult, then you start leveling it. And by leveling it, that means that you are exerting more pressure on the upper teeth. And that might result in a broken teeth, for instance. It's expressed in Newton, and around 70 Newton, it starts breaking the teeth. depending on the status of your teeth, obviously. So we were measuring the pressure on the upper teeth, as you can see here, and you see a number of patients with a malempathy grade 1 till 4. And with on the top, with the classic direct laryngoscope, you see that the newtons in grade 1 are 18, and that goes up till 50 in malempathy grade 4. But with videolaryngoscopies, it does not go up, and it's much lower. So, in fact, protecting our patients' teeth. And if you see the Cormac-Lehane grade, it's a bit similar. With the classic laryngoscope, it goes up all the way till 50, but with videolaryngoscopy, it is very low, and in fact, we don't even have these 3 and 4s anymore. Yeah? All these studies were done completely blinded to the anesthetist. It was recorded on laptops, but without any knowledge of ourselves. We published that in Anesthesia and Analgesia. As you can see here, the force is exerted on upper teeth. On general, with a Macintosh laryngoscope, classic direct laryngoscopy, on the left side, you have these forces up till 30 Newton. With videolaryngoscopy, it depends on which laryngoscope, which videolaryngoscope you're using. There are still differences because it can be sometimes a little bit difficult with one videolaryngoscope compared to another one. But with the Macintosh videolaryngoscope, the CMAC, you see it is one of the lowest. Again, this was completely blinded and recorded, and we only could see it afterwards. This is a particular very interesting patient in that group, and afterwards we made a picture of the mouth opening, which was very limited in this BMI 36 kilogram per square meter, malempathy grade 4, interdental distance 2.9, normally should be at least 3.5, a theromental distance 5.5 centimeters, normally should be 6.5 or more, and a Cormac-Lehane grade 4. Quite a challenge, and indeed, we tried to intubate these patients, and we had 3 attempts with a classic laryngoscope. We were not successful to intubate these patients. Then we were using the videolaryngoscope, and immediately intubation was successful at the first attempt, and not only that, but you could see the force exerted on the upper teeth was really much lower. So again, there's that advantage, and we published these results as well. It also reduces the hemodynamics. It's a pity I don't have a pointer here, but the top 2 you see, these are patients where normal classic laryngoscopes were used, and the lower 2, the red and the green ones, are with videolaryngoscopy. And you clearly can see there are differences when you're doing intubation. It increases your heart rate, it increases your blood pressure, and it decreases a little bit when you're using the beta blockers. Videolaryngoscopy is also ideal in difficult situations. Just to show you a patient, this is a patient, a cleaning lady at a neighboring hospital in Eindhoven where I was working, and that was a psychiatric hospital. This patient was attacked by one of the psychiatric patients, and a pair of scissors was put right into the center of thoracic spine. You see, this is during the operation. And the surgeons asked us not to intubate, not to change the position of the patient. See, underwent, you could see here that the blade of the scissor was really on the wrong side, yeah, of the thoracic spine, and they really asked us, don't move this patient anymore, otherwise you will have a paralyzed patient. Yeah? In fact, it was very easy because we took the patient a little bit in front of the operating theater. I sat on the ground and I intubated the patient. It's not a real issue because we really teach our trainees how to do intubations in different positions. So in the supine position, in the lateral position, in the prone position, in the sitting position. That's how we teach them all the time. So it was not really an issue for me to do that, and in fact it was rather easy to do the intubation. We tried using the awake fiber optic technique, but that was not successful. And I'm showing this, you can do that in accident and emergencies as well. So we published all this kind of information. You actually have now the CMAC pocket monitor, where you actually can turn upside down the monitor itself so that right stays the right, otherwise you might be blurred with your vision. And you can see in the middle, so on the left side, this is the top one, A, that's a supine position, B, that is in the lateral position, E, that is the monitor in the correct position, yeah, and the lower left as well. But on the right side, picture C, that is with the patient in the sitting position. And you see actually that I have now my laryngoscope in the right hand and the endotracheal tube in the left hand, okay? Because that's much easier. Also in the sitting position, use your laryngoscope in the right hand and the endotracheal tube in the left hand. But you have to put your monitor upside down, so that you actually have the right of the monitor still on your right side. And you can do that also with the pocket monitor. We all published all these kind of things. Yeah? This is the pocket monitor. It's easy to change the side of the blade. We also teach our junior staff and our senior staff in a skills lab. This is the skills lab I had in my former position, where we actually could train whoever wants to learn about videolaryngoscopy, about ultrasound, and all kinds of things in anesthesia. And I think that's much better to be done. Now, this is a very ill patient, 40 plus degrees of Celsius. And at the back, you see the ENT surgeon. He just saw that patient at the accident and emergency department, and he was really, well, really nervous because he showed all the signs and symptoms of an acute epiglottitis. Now, everybody in the room knew exactly what to do. I even put 2 of my videolaryngoscopes ready to use so that I was 100% sure that one of the 2 would help me during the intubations. Yeah? I put the patient to sleep after pre-oxygenating the patient for a couple of minutes. Yeah? Everybody knew exactly what to do, and there was a team ready at hand to do a surgical tracheostomy if there was a need to. And so the ENT surgeon was there. Now look at the monitor, what you can see with an acute epiglottitis where you see a lot of saliva. Yeah? Never suck it out in the area of the vocal cords because you will end up with a glottis spasm, and a glottis spasm is not really helpful in these kind of situations. So suck out on the side and use an endotracheal tube size 5, for instance, which is easy to be inserted. And as you can see, the typically very red enlarged epiglottis, that is what you see with acute epiglottitis. And in fact, I've done 6 of similar cases, putting the patient to sleep in a well-controlled environment and not exposing those patients. They are really ill, and not exposing them to that fate of undergoing awake fiber optic intubation. A difficult case can be whenever there's a tumor inside the mouth. Yeah? This is a case of a 70 years old patient, male, undergoing cystectomy and BRCA operation. But 6 months before, he had a carcinoma of a tumor of the base of the tongue, and they operated upon him, and he was, after the surgery, he was treated with radiation therapy. But that's all gone 6 months before. But you know, these kind of patients, they can't move their mouth anymore, and he showed a Mallampati 4 and a coronary Lehane grade 4. Not very easy to do that kind of intubation. And even with the videolaryngoscope, we had the Lehane grade 3, as you can see on the left. And with lots of manipulation, we got to see the arytenoids, and we managed to put in our gum elastic bougie. Another case which was a difficult one is, for instance, this case. This patient was operated upon for a very large tumor of the lip, maybe 4 months before. Now she came back for restoration of the lips. Okay, plastic surgery. We only could fit in the laryngoscope, but we couldn't see anything ourselves. But you do not need to see because you can look on the monitor to insert your endotracheal tube into position. And we published that in the Journal of Anesthesia. This is a particular lady. I was called on a Sunday evening by one of our well-experienced in airway management staff member. And he called upon me and said, please come to the hospital. You need to give me a hand because I have a really difficult case. That patient was eating nuts and she got an allergic reaction to nuts. And by the minute you could see she was blowing up everywhere. Yeah? Everything was increasing in size. And for instance, this was the tongue a few minutes later. She was not protruding it. Yeah? It was like such when I came to the hospital. We put her asleep after examining her, obviously, and you can see on the top right hand the mask we were using, and you see the tongue, the enlarged tongue in the mask over there. And somebody took a picture, and I was very thankful for that, because you can see the edematous area not only from the outside, but also from the inside. Yeah? You see the epiglottics, but also the rest is swollen very much. But it was very easy to do the intubation using the videolaryngoscope. In fact, and see the top left one, I had to create some room and move the tongue in order to put in the endotracheal tube. There was a team ready to do a tracheostomy if this would not be successful. But as you can see, we were very successful in doing so. At the accident and emergency department, they can use videolaryngoscopy. My colleagues at the military, they are using videolaryngoscopy. And for the difficult cases, they have now produced a D-blade. The D-blade, and it resembles also the acute blade of the glide scope. As you can see, if you put them together on the left side, they are very much the same. You only need to use those in the very difficult ones. And I mean, that's the 1% of your patients. For the rest, just keep it with your normal Macintosh blade laryngoscope. It has been there for 75 years, and there must have been a reason why that blade has been so successful over the years. Yeah? Now, I also will show you a combination technique. Suppose there is a very difficult intubation, you also can use the Bonfils. The Bonfils is like a fiber optic, but then a rigid one. Yeah? Now I'm using the equipment of the surgeons, as you can see, the top left. And in my hands, I have the left hand, I have my videolaryngoscope. In the right hand, I have the Bonfils. Yeah? I try to expose with my videolaryngoscope in my left hand to have the best possible view, and then I'm going to do the intubation with the Bonfils. Yeah? That's the intention. You see, both myself and my assistant are looking on the monitor doing this intubation. And you see the different angles, and the left hand is a videolaryngoscope, the right hand is the Bonfils, loaded with the endotracheal tube. We published that in the British Journal of Anaesthesia. This combination technique, you see the images on the left side, that is what you see with the videolaryngoscope. On the right side, that's what you see with the Bonfils, okay? Yeah, so this is a video clip of the actual combination technique. So with the videolaryngoscope, even the best view you will have is a Cormac-Lehane grade 3. With direct laryngoscopy, you couldn't see anything, but when you come and have the intubation with the Bonfils, you just go behind it, and you actually really can go between the vocal cords and now offload your endotracheal tube into position. You will see it in a moment. You see also the tracheal rings, and that combination is very useful to solve the very difficult problems. As you can see, the carina at the end. So the indication for the D-blade are the difficult airways. I mean, the very difficult ones, that's the 1%, and a Bonfils can help you also in a narrow airway. If there's no distance, between the teeth, you still can do an intubation going in between your cheek and the teeth. And so that's also a useful thing. And you can add on other things as well. Obviously, people will say, yeah, why using a reusable blade? Why can't we use a disposable blade? That's a discussion I'm not going to have today. I think the quality of the disposable blade is still less than the reusable blades, but that's another discussion. Now, the difficult airway algorithm, look it up at the ASA difficult airway algorithm, the latest one published in 2013. And this is also published by VIDA in the Journal of Clinical Anesthesia, the American Difficult Airway Society. And as you can see in red, yeah, they suggest to try 3 attempts with your classic laryngoscope and then use a videolaryngoscope immediately afterwards. No more mentioning of fiber optic intubation whatsoever in either the ASA difficult airway or this one. And they just tell you, use a laryngeal mask to buy some time. But why aren't we using videolaryngoscopy all the time if that is the better technique? That is what we are doing nowadays. And some say, well, you can lose your skills if you only do videolaryngoscopy. So what are we doing with direct laryngoscopy? There was a letter to the editor in Acta Scandinavica, and I wrote an answer to that, as you can see in here. And I think if you're using Macintosh blade laryngoscopes as a videolaryngoscope, you still can do and use it as a direct laryngoscopic technique. There's no reason why you should not do that. So I don't think you will lose your skills if you do that. Some items which you should not do, and videolaryngoscopy to unlearn and forget, don't think you can do an intubation on yourself. You still need help from your anesthetic technician or registrar or whatever. Don't put it in too deep or too fast. I see it all the time. Our colleagues, they want to do an intubation very fast, but that can be traumatic for a patient. Do it gently. If you have pre-oxygenated the patient, there's 8 minutes to do an intubation. So why should you do it within 10 seconds? Yeah? Take your time, make sure that you do all the movements in the correct way, and produce a nice and a good view. That is what you do. Don't panic. There's always a way out, and there are several issues what you can do. A size 4 fits all ways. That's not true. Start with a size 3. A size 3 will fit in 80 or more % of our patients. And the size 4, you really very seldom need that one. And of course, there are other sizes for pediatrics as well. Awake intubation, I've not done it as yet. It might be possible with videolaryngoscopy, but I'm unsure. So check your equipment as you always have to do. Insert it under direct vision because you want to avoid trauma to that palatopharyngeal fold, or other areas into the mouth. Create enough room, so move your laryngoscope from the right to the left. Get a good view of the vocal cords, intubate with care, but be gentle, and check it as usual. So I really think videolaryngoscopy offers much more than classic laryngoscopy. And I thank you for your attention.
Well, thank you very much. Unfortunately, time expired. I'm sure Professor van Zundert would be very happy to take any of the questions that you might have at the front. And it remains for me to, again, thank all 3 of our speakers. We do have a small token for them. I hope it's not very heavy, but it's a bit bulky, so hopefully they'll have some space in their luggage to take our gifts. And again, it remains for me to thank you for attending this session, and enjoy your lunch.